Let's see, is that working? Great. Thanks, Shalmali, for the beautiful introduction. I just wanted to thank the organizers of this event. This is my first year here. It's fantastic. This is my favorite type of conference. It's the right size and the right mix of just wildly different backgrounds. That's like where all the most exciting things happen. So pleasure to be here. Also to thank our hosts at Mayo. You guys have just been leading the way in so much of this work. It's really an honor to be here. It's my first time, so thank you. So I'm going to be talking today about work that is maybe broadly in the bucket of causal AI, and specifically talking about work that we're doing training a foundation model on EHR data. We're calling it large clinical behavioral model, and then combining that with formal causal inference methods to actually develop new ways of impacting patient care. So this is joint work with John Kolstad, Jonas Neck, both from UC Berkeley, Econ and Business, and Anna Zink, who's now a professor at Tufts. Great, so I'm gonna start with a basic premise. I think it won't be controversial, but it's worth going back to our roots sometimes. So at the heart of the practice of medicine are people. And these are highly skilled human beings making high stakes decisions in very complex dynamic environments. So this is a graphic from 10 years ago, but still applies. It's focused on the diagnostic process. The diagnostic process, again, it won't come as a surprise to people in this room, but is complex. It involves ordering many procedures, labs, gathering information, getting results, interpreting them, iterating them. This is done, again, in a complex environment. And I think this is a really important point. It still very much depends on the cognitive assets of individual skilled humans. And much of that knowledge is not encoded in language. It is tacit learning. So it's learning based on experience and practice. So you can think about the diagnostic process that way. And this diagram was from a paper on diagnosis. Importantly, the treatment process is very much the same. So I think probably not folks in this room, but many out in the world think that all of the right answers in medicine exist. They exist in clinical trials, they exist in the published literature, they exist in textbooks, they exist in guidelines. And if we could just somehow gather all of that together and make it available, things would be solved. And I think it's very important to take a step back and think about all the ways that that evidence base, important though it is, foundational though it is, falls short. So when you're treating a real patient in front of you, you're treating a very complex person. They often have multiple conditions. They have long, complex histories. They're often on multiple medications. And then they have other things going on in their lives. So there's limited information, important but limited information in that published language base on how to treat the patient in front of me right now in a way that works for them. So where does that knowledge exist then? Again, it exists in the brains of these skilled practitioners who are out there actually taking care of real patients day by day. We talk about like sort of like recipe medicine, cookbook medicine. It will get us a certain amount of the way, but it won't get us all the way there. What we really need are ways to tap into that knowledge, that deep clinical knowledge that doesn't exist in language. We're in this kind of crazy situation where you might argue that some of the most valuable knowledge that we collectively as human beings have ever produced is only in the actions of these skilled providers acting out in the world. And that our current approaches, including large language models, aren't going to solve that for us. And I think we've heard some of the cutting edge. This has been a phenomenal day of how people are trying to push that, but I just want to say it explicitly. Sometimes an analogy we use to talk about this is thinking about autonomous vehicles. So you would never dream of training an autonomous vehicle based on like the driver's manual, and you also wouldn't take a video and then turn it into text and then have the vehicle learn based on that how to drive. So there's a lot in common with healthcare in the sense that it's high stakes, it requires multimodal reasoning, but think the difference in complexity between autonomous vehicles and medical care. So to drive a car, we take a 16, 15-year-old, and I have a 14-year-old, so this is truly terrifying, send them to school for a little bit, and then they take a test and they're out in the world. To be a licensed practicing physician, we train for much, much longer, and especially for the complex subspecialties, decades. So this is a very complicated task, and language will get us part of the way there. So just to take an example, AI scribes. So two wonderful sponsors of this excellent technology here. Clearly this is having an impact. So for those, I think for anyone who in the room who probably is no one, not aware. So basically you can take ambient recordings of patient encounters, turn them into notes. The clinicians can edit the notes. And there are many benefits to this. So clearly we're in a time where providers are overworked. We have provider shortages. It can reduce burnout. It can potentially improve patient-provider interactions, and also many sort of well-documented limitations. So the potential for hallucinations, not able to quantify uncertainty. I mean, also, depending on who you talk to, some providers will say, well, that actually doesn't save me much time because before I would just copy and paste the note, and now I've got a scribe. Leaving all that aside, because I think this technology is evolving rapidly and getting better, I want to just point out a much more fundamental task, which is as these language-based technologies like scribes evolve, it's very easy to go, and I think we'll see this evolution from recording an interaction and generating a note to proactively querying the EHR for a history and pre-charting, which already is an intervention because you're selectively raising up information for providers to see, to actually starting to suggest, oh, might you like to consider this procedure? Might you like to consider this treatment? And this is a really core point. These language models are at their core designed for a different task. Now I realize this is a bit of a simplification, but nonetheless, I think it's worth coming back to. Fundamentally asking which words come next in text is a very different question from which clinical actions should come next in time. So I'm going to talk now about a new approach to tackling this kind of a problem, which I think is actually very complementary to a lot of the work going on with the language models. So we talked about having all of this deep clinical knowledge that does exist, really encapsulated in the mind of skilled practitioners seeing real patients. The fortunate thing is that medicine is pretty unique, at least among the highly skilled professions, in the extent to which this action space, human behavior, is actually captured electronically. Now, absolutely, EHRs are not perfect. There are biases, there are missing data. I'm going to come back to that later in the talk, but just to call that out now for those of you who are scratching your head. But nonetheless, it's extremely rich data. So our basic premise is coming off of a kind of fundamental tenet of economics for a long time, which is that tacit knowledge exists, and the best way to access that is through human behavior. Human behavior encodes knowledge. So what we're doing is building a large clinical behavioral model to learn, quote unquote, the language of medicine, but really saying we need to move from learning really in a semantic language space to learning in a temporal action space. If we're going to learn from this rich encoding of how medicine is practiced. So I'm going to just walk through a little bit of what this looks like. I think, again, this type of data is familiar to most people here, but worth grounding on. So here's a real-world example of a patient's order path. This is taken from a real example, UCSF emergency department. So a 70-year-old woman comes into the emergency department complaining of chest pain. And so this is where sort of the order path starts. So then a bunch of diagnostic tests are ordered, procedures are ordered, results are returned. This happens over time, recorded in the EHR. Eventually you reach diagnosis, and actually beyond that, diagnoses, interventions, and of course patient outcomes as well. So what does the large clinical behavioral model make of this, or how does it work? So first of all, what it does is it's going to take, at each temporal step, the rich patient context, all the information about the patient available at that step. And then what it's going to generate is a prediction over the next set of actions, sort of a probability distribution over the next set of actions. And this is going to move forward in time dynamically. So now as that information set evolves, then the predicted next action set also evolve. Excuse me. So what happens here with this patient? So this 70-year-old woman is moving along. Initially, she has a bunch of classic MI or heart attack labs ordered. as a transthoracic echo. So then something interesting happens. This is again a real patient, CT brain without contrast. So before seeing that action, what's the large clinical behavioral model saying? It's basically thinking, it's going along the path of a heart attack or an MI. So before it sees that action, it's giving that action a pretty low probability. But what's interesting is that once it sees that action, it's able to realize this is actually pivotal information that suggests we're going off down a whole new diagnostic trajectory. So in this case, off onto cerebral hemorrhage or a stroke, patient subsequently gets a bunch of workup along that, and that ends up being the diagnosis. And you can contrast that with how sort of at least an off-the-shelf large language model handles that information, because it's lacking this sort of rich temporal action context. So this is GPT-4o, is essentially ends up looping around on a heart attack or MI workup, because that's what the preponderance of all the history that came before is suggesting. Okay, so that's part one, large clinical behavioral models, and we sort of talked about the benefit at a simplified level of moving from which word usually comes next in text to which clinical actions are likely to come next in time. So far I've really been only talking about prediction though, so which actions are likely in time. And that raises an important question. If you see one of these unexpected actions or a pivotal action, in this case the CT brain, does that represent good care or bad care? Is that really an aberration? You should have said, wait, are you sure you want to do that? Or actually, is this actually exactly what you want to be doing for accelerated diagnosis in this case? And so for that, I want to use the rest of the time now talking about how you can combine large clinical behavioral modeling with formal causal reasoning. So this is really this next step of not which actions are likely to come next, but which actions should come next. And if we start to be able to unlock those questions, then we've got the potential to really leverage this massive source of information, data, knowledge that we have to optimize care pathways and to ask questions about hypotheticals. So how could you improve patient outcomes, a healthcare system efficiency, and a whole range of other outcomes? So to walk a little bit through how this works, causal models are at the core of it. So one thing we can do is we can represent essentially this data generating process using a causal directed acyclic graph. So I'm showing a simplified version of one there, but at its core, this describes what we know about the process of clinical care. So over time, at the most abstract level, patients have states. There's actually all their medical history, multimodal information that's available about them, the context of what's going on in the care system around them. And then in response to those states, providers take actions. Those actions both affect future states and reveal information about the states. Those in turn affect future actions, and then ultimately we have outcomes. So what we want to learn then at a basic level is which actions over time in response to patient states are going to optimize outcomes. And I'm going to refer to this as a clinical behavioral policy. Importantly, this is just implicitly the algorithm that providers are following in their heads, not explicitly when they're treating patients. They're plotting out care paths and ways of responding to dynamic information to try to optimize outcomes. I think it's also worth saying here that by outcomes, we can think of clinical outcomes, we can think of efficiency outcomes, we can think of sort of speed outcomes, so many ways to contextualize outcomes in this sense, in this state. All right, so we now want to ask which actions in response to patient states would optimize outcomes. So folks in this room from Causal may say, okay, well, this seems like a pretty easy problem. Why don't we just we've got this vast data source, let's just match patients who got different care and then compare their outcomes. Does this work? Well, the short answer is no. There's a couple reasons why it really doesn't work. The first is that we care about these longitudinal action paths. So even if you match patients perfectly based on their characteristics at the start of this encounter, depending on those initial actions, that will affect future states. And those future states are both part of the causal pathway you care about, but they're also confounders for the effects of future actions. They mean that your patient groups are no longer matched when you look at post-baseline actions. So this is a well-described phenomenon of time-dependent confounding. It goes back to Jamie Robbins in the 80s. There are ways to deal with it, but they are not easier off the shelf. I want to talk now, though, a little bit about another challenge, which is maybe even more pernicious, which is all the unmeasured factors. So basically, what these approaches require is that you measured all the key common drivers of both actions and outcomes. And we know in the healthcare system this is often not true. So there may be lots of ways in which patients who get a certain diagnostic test or a procedure or a treatment are different from those that did not get it, based on things we didn't capture in the healthcare system. So with that motivation, then, I'll give an overview of what we're calling deep causal behavioral policy learning, which is tying together this large clinical behavioral model with these formal causal reasoning frameworks to tackle this challenge. So there's 3 basic steps of this approach. At the first step, what we're going to try to do is learn personalized matches of patients to providers. So we're going after who are the causally best providers for patients like this. The second step is modeling provider-specific clinical practice. And here we're leveraging this large clinical behavioral model, but then fine-tuning it to the behavior of specific providers. And then the third, we can put that together and actually say, okay, what are the causal shifts and outcomes we'd expect to see by changing practice patterns in these ways? So I'll say a few words about each of these. So first, this personalized match of patients to skilled providers. So this ties into folks who are familiar. First of all, this is very much within the counterfactual framework of, some people like that, some people don't, of causal inference. When we ask this question, we're essentially saying, how would outcomes have differed for a group of patients if we hypothetically had assigned them to different providers with, say, different skill sets or different backgrounds? Importantly, so this is leveraging a large literature, again, for a long time, premised on this idea that there is more natural experimentation in provider assignment. So people can talk a lot about using providers as instrumental variables, so that unmeasured confounding becomes less of a challenge for when you look at the effects of provider assignment compared to if you look at the effects of individual actions. So we can do things like leverage shift changes or days of the week, condition on obviously context and setting. You wouldn't want to stop there, though, and this is where sort of the causal machine learning, one of the places the causal machine learning comes in. First, you don't want to assume that just only conditional on shift patients seen by different providers are identical. You often want to actually adjust for all of the other measured ways that patients seen by different providers are different. And this is where techniques for essentially using machine learning to do flexible adjustment for very high dimensional confounders comes in. So examples would be a targeted maximum likelihood estimation. So that's an example of where we're using machine learning as an ingredient to get a better control of measured confounders to go after these provider-specific effects. Now, the second piece of this, where this sort of causal ML comes in, is really about this personalized patient-provider match. So Dr. Yao talked about causal forest. That's a great example. So there's all this, again, very nice literature on using machine learning to discover treatment effect heterogeneity and to understand which types of patients would benefit from which treatments. The idea here is that we're applying that same machinery, but now the provider is the treatment. So we're saying which types of patients which providers would result in the best outcomes for patients like you. Moving now to the second piece of this deep causal behavioral policy learning. This is where now we've identified high-performing providers for patients like you, and now we're really leveraging advances in AI and transformers to, really for the first time, be able to actually encapsulate what provider-specific practice patterns look like. So this step is 2 steps. One is the training of this large clinical behavioral model. So we're pre-training this on large multimodal data, agnostic to providers, using transformer architecture and really treating this as a sequence-to-sequence task of action predictions. And then, again, importantly in the temporal action space and not in the language space. And then taking that pre-trained model and then fine-tuning it to the practice of specific providers. And then this final piece, which is really quantifying the impacts of these different practice patterns. And so here it's worth highlighting a key assumption, which is that providers are having these causally optimal outcomes on patients via things we capture in our data set, in the EHR. So we need that really we can pick up these provider-specific optimal pathways, but for them actually to be the driving force behind these good outcomes, we actually want the ways in which providers are achieving those outcomes to be captured in the EHR. And I would say this is a place where this is going to get more and more reasonable as we get more and more complete data capture. And it's actually there's several, but one of the very interesting intersections, I would say, of this work and the LLM work, and in particular the ambient scribing work, is our ability to continue to build that out so we get more and more meaningful practice paths. And so I will just close by saying so far I've been talking about a sort of general approach to unlocking existing clinical expertise that exists in our data, but is highly siloed, and thinking about how can we really think about ways of encoding that and ensuring that deep clinical knowledge flows to all the patients and places that it could do so much good. So I have another hat, not wearing as much today, but just to say that we're facing profound provider shortages, provider burnout, but also globally that we need ways to have expertise flow to new places. However, that's all sort of premised on encoding and unlocking existing expertise. What about generating new knowledge? And so here, just talk briefly about a link to work we're doing on AI-based co-pilots for generating causal evidence. So this is, again, based on the fact that there's really decades of work in causal inference, machine learning, statistical inference, how to put them together to actually query complex observational data for complicated causal questions, like long-term dynamic treatment policies, for example. How do you change and modify a treatment over time in response to evolving characteristics? But right now, the ability to ask those questions is also siloed because the tools exist in a bunch of theoretical papers and hard-to-use code. And so one thing I'm really excited about is actually using AI to democratize access to those tools. And where is the link to the large clinical behavioral model? For those of you who do work in causal inference, you can think about it as like the pre-trained model being like a very general propensity score model that could then be fine-tuned to a specific causal task. So, beyond that, really one of the appeals of generative models is they suggest new ways of doing things. So we have generative AI suggesting new ways to play games we've never thought about, fold proteins, discover drugs. So why not have generative AI suggesting whole new ways of delivering healthcare that we haven't considered? And then couple that with a robust evaluation apparatus. So where are we at with this? So the first prototype was built using smaller scale UCSF data. Second prototype's in partnership with Providence Health, and what we're doing now is scaling this in much larger data environments. Very excited about this. There was an amazing roundtable about foundation models that I got to pop in before. I think this is really a new foundation model approach that opens up a lot of applications. We talked about kind of real-time clinical decision support, next generation quality, a lot of potential for interaction with large language models, both to clinically ground the large language models, but obviously also for the LCBM itself. I said not all knowledge exists in language, but clearly there's a lot of medical knowledge that is in language. And so really I think the partnership between these types of models is a very fruitful direction. So just with that, just to acknowledge my co-authors on this working paper and partnerships with UCSF and Providence. Thanks so much.